Myocardial infarction or acute myocardial infarction, commonly known as a heart attack, occurs when blood flow stops to a part of the heart, causing damage to the heart muscle. The most common symptom is chest pain or discomfort, which may travel into the shoulder, arm, back, neck, or jaw. Often it is in the center or left side of the chest and lasts for more than a few minutes. The discomfort may occasionally feel like heartburn. Other symptoms may include shortness of breath, nausea, feeling faint, a cold sweat, or feeling tired. About 30% of people have atypical symptoms, with women more likely than men to present atypically. Among those over 75 years old, about 5% have had ANMI with little or no history of symptoms. ANMI may cause heart failure, an irregular heartbeat, or cardiac arrest. Most MIS occur due to coronary artery disease. Risk factors include high blood pressure, smoking, diabetes, lack of exercise, obesity, high blood cholesterol, poor diet, and excessive alcohol intake, among others. The mechanism of ANMI often involves the complete blockage of a coronary artery caused by a rupture of an atherosclerotic plaque. MIS are less commonly caused by coronary artery spasms, which may be due to cocaine, significant emotional stress, and extreme cold, among others. A number of tests are useful to help with diagnosis, including electrocardiograms, blood tests, and coronary angiography. An ECG may confirm its elevation MI if elevation is present. Commonly used blood tests include troponin and less often creatine kinase MB. Aspirin is an appropriate immediate treatment for a suspected MI. Nitroglycerin or opioids may be used to help with chest pain. However, they do not improve overall outcomes. Supplemental oxygen should be used in those with low oxygen levels or shortness of breath. Instant elevation MIS treatments which attempt to restore blood flow to the heart are typically recommended and include angioplasty, where the arteries are pushed open, or thrombolysis, where the blockage is removed using medications. People who have a non-instant elevation myocardial infarction are often managed with the blood thinner heparin, with the additional use of angioplasty in those at high risk. In people with blockages of multiple coronary arteries and diabetes, bypass surgery may be recommended rather than angioplasty. After ANMI, lifestyle modifications, along with long-term treatment with aspirin, beta blockers, and statins, are typically recommended. Worldwide, about 8.6 million myocardial infarctions occurred in 2013. More than 3 million people had an instant elevation MI and more than 4 million had an NSDEMI. SDEMIs occur about twice as often in men as women. About 1 million people have ANMI each year in the United States. In the developed world, the risk of death in those who have had an STEMI is about 10%. Rates of MI for a given age have decreased globally between 1990 and 2010. Signs and symptoms. The onset of symptoms in myocardial infarction is usually gradual over several minutes and rarely instantaneous. Chest pain is the most common symptom of acute MI and is often described as a sensation of tightness, pressure, or squeezing. Chest pain due to ischemia of the heart muscle is termed angina pectoris. Pain radiates most often to the left arm, but may also radiate to the lower jaw, neck, right arm, back, and upper abdomen, where it may mimic heartburn. Levine's sign, in which a person localizes the chest pain by clenching the fists over the sternum, has classically been thought to be predictive of cardiac chest pain, although a prospective observational study showed it had a poor positive predictive value. Shortness of breath occurs when the damage to the heart limits the output of the left ventricle. causing left ventricular failure and consequent pulmonary edema. Other symptoms include diaphoresis, weakness, lightheadedness, nausea, vomiting, and palpitations. These symptoms are likely induced by a massive surge of catecholamines from the sympathetic nervous system, which occurs in response to pain and blood flow abnormalities that result from dysfunction of the heart muscle. Loss of consciousness and sudden death can occur in MIS. Atypical symptoms are more frequently reported by women, the elderly, and those with diabetes when compared to the male and younger counterparts. Women also report more numerous symptoms compared with men. The most common symptoms of ME in women include dyspnea, weakness, and fatigue. Sleep disturbances, and dyspnea have been reported as frequently occurring symptoms that may manifest as long as 1 month before the actual clinically manifested ischemic event. In women, chest pain may be less predictive of coronary ischemia than in men. Women may also experience back or jaw pain during an episode. At least 1/4 of all MIS are silent, without chest pain or other symptoms. These cases can be discovered later on electrocardiograms, using blood enzyme tests, or at autopsy without a prior history of related complaints. Estimates of the prevalence of silent MIS vary between 22 and 64%. A silent course is more common in the elderly, in people with diabetes mellitus, and after heart transplantation, probably because the donor heart is not fully innervated by the nervous system of the recipient. In people with diabetes, differences in pain threshold, autonomic neuropathy, and psychological factors have been cited as possible explanations for the lack of symptoms. Any group of symptoms compatible with a sudden interruption of the blood flow to the heart, which includes STEMI, NSDEMI, or unstable angina, are called an acute coronary syndrome. Causes. Many of the risk factors for myocardial infarction are modifiable, and thus many cases may be preventable. Lifestyle smoking appears to be the cause of about 36%, and obesity the cause of 20% of coronary artery disease. Lack of exercise has been linked to 7 to 12% of cases. Less common causes include stress-related causes such as job stress, which accounts for about 3% of cases, and chronic high stress levels. Tobacco smoking and short-term exposure to air pollution such as carbon monoxide, nitrogen dioxide, and sulfur dioxide have been associated with ME. Other factors that increase the risk of ME and are associated with worse outcomes after ME include lack of physical activity and psychosocial factors including low socioeconomic status, social isolation, and negative emotions. Shift work is also associated with a higher risk of ME. Acute and prolonged intake of high quantities of alcoholic drinks increase the risk of a heart attack. The evidence for saturated fat is unclear. Some state there is evidence of benefit from reducing saturated fat, specifically a benefit from eating polyunsaturated fat instead of saturated fat, while others state there is little evidence that reducing dietary saturated fat or increasing polyunsaturated fat intake affects heart attack risk. Dietary cholesterol does not appear to have a significant effect on blood cholesterol, and thus recommendations about its consumption may not be needed. Trans fats do appear to increase risk. Disease, diabetes mellitus, high blood pressure, dyslipidemia, high levels of blood cholesterol, particularly high low-density lipoprotein, low-high-density lipoprotein, high triglycerides, endometriosis in women under the age of 40, and obesity have all been linked to ME. A number of acute and chronic infections, including chlamydophila pneumoniae, influenza, Helicobacter pylori, and Porphyromonas gingivalis among others have been linked to atherosclerosis and myocardial infarction. As of 2013, there is no evidence of benefit from antibiotics or vaccination, however, calling the association into question. Myocardial infarction can also occur as a late consequence of Kawasaki disease. Genetic genome-wide association studies have found 27 genetic variants that are associated with an increased risk of myocardial infarction. Strongest association of ME has been found with the 9p21 genome at locus, which contains genes CDKN2A and AMP2B. Although the single nucleotide polymorphisms that are implicated are within a non-coding region, the majority of these variants are in regions that have not been previously implicated in coronary artery disease. The following genes have an association with ME: PCSK9, SORT1, MIA3, WDR12, MRAS, PHACTR1, LPA, TCF21, MTHFDSL, ZC3HC1, CDKN2A2B, ABO, PDGF0, APOA5, MNF1, ASM283, COL4A1, HIPC1, SM83, ADAMTS7, RAS1, SMG6, SNF8, LGLR, SLC5A3, MRPS6, KCNE2. Other. At any given age, men are more at risk than women, particularly before menopause, but because in general women live longer than men. Ischemic heart disease causes slightly more total deaths in women. Family history of ischemic heart disease or ME, particularly if one has a first-degree relative who suffered a premature myocardial infarction at 65. Women who use combined oral contraceptive pills have a modestly increased risk of myocardial infarction, especially in the presence of other risk factors, such as smoking. Heart attacks appear to occur more commonly in the morning hours, especially between 6 a.m. and noon. Evidence suggests that heart attacks are at least 3 times more likely to occur in the morning than in the late evening. Old age increases risk of a heart attack. Pathophysiology. Acute myocardial infarction refers to 2 subtypes of acute coronary syndrome, namely non-SYNT elevated and SYNT elevated MIS, which are most frequently a manifestation of coronary artery disease. The most common triggering event is the disruption of an atherosclerotic plaque in an epicardial coronary artery, which leads to a clotting cascade, sometimes resulting in total occlusion of the artery. Atherosclerosis is the gradual buildup of cholesterol and fibrous tissue in plaques in the wall of arteries, typically over decades. Bloodstream column irregularities visible on angiography reflect artery lumen narrowing as a result of decades of advancing atherosclerosis. Plaques can become unstable, rupture, and additionally promote the formation of a blood clot that occludes the artery. This can occur in minutes. When a severe enough plaque rupture occurs in the coronary arteries, it leads to ME. It is estimated that 1 billion cardiac cells are lost in a typical ME. If impaired blood flow to the heart lasts long enough, it triggers a process called the ischemic cascade. The heart cells in the territory of the occluded coronary artery die and do not grow back. A collagen scar forms in the place. Recent studies indicate that another form of cell death, apoptosis, also plays a role in the process of tissue damage following an ME. As a result, the person's heart will be permanently damaged. This myocardial scarring also puts the person at risk for potentially life-threatening abnormal heart rhythms, and may result in the formation of a ventricular aneurysm that can rupture with catastrophic consequences. Injured heart tissue conducts electrical impulses more slowly than normal heart tissue. The difference in conduction velocity between injured and uninjured tissue can trigger re-entry or a feedback loop that is believed to be the cause of many lethal arrhythmias. The most serious of these arrhythmias is ventricular fibrillation, an extremely fast and chaotic heart rhythm that is the leading cause of sudden cardiac death. Another life-threatening arrhythmia is ventricular tachycardia, which can cause sudden cardiac death. However, VT usually results in rapid heart rates that prevent the heart from pumping blood effectively. Cardiac output and blood pressure may fall to dangerous levels, which can lead to further coronary ischemia and extension of the infarction. The cardiac defibrillator device was specifically designed to terminate these potentially fatal arrhythmias. The device works by delivering an electrical shock to the person to depolarize a critical mass of the heart muscle, in effect rebooting the heart. This therapy is time-dependent, and the odds of successful defibrillation decline rapidly after the onset of cardiopulmonary arrest. Myocardial infarction in the setting of plaque results from underlying atherosclerosis. Inflammation is known to be an important step in the process of atherosclerotic plaque formation. C-reactive protein is a sensitive but non-specific marker for inflammation. Elevated CRP blood levels, especially measured with high-sensitivity assays, can predict the risk of ME, as well as stroke and development of diabetes. Moreover, some drugs for ME might also reduce CRP levels. The use of high-sensitivity CRP assays as a means of screening the general population is advised against, but it may be used optionally at the physician's discretion in those who already present with other risk factors and known coronary artery disease. Whether CRP plays a direct role in atherosclerosis remains uncertain. Calcium deposition as calcification is another part of atherosclerotic plaque formation. Calcium deposits in the coronary arteries can be detected with CT scans. Several studies have shown that coronary calcium can provide predictive information beyond that of classical risk factors. Hyperhomocystinemia in homocystinuria is associated with premature atherosclerosis. Whether elevated homocysteine in the normal range is causal is controversial. Pathological types. The two main types of acute myocardial infarction, based on pathology, are transmural AMI is associated with atherosclerosis involving a major coronary artery. It can be subclassified into anterior, posterior, inferior, lateral, or septal. Transmural infarcts extend through the whole thickness of the heart muscle and are usually a result of complete occlusion of the area's blood supply. In addition, on ECG, SAINT elevation and Q waves are seen. Subendocardial AMI involves a small area in the subendocardial wall of the left ventricle, ventricular septum, or papillary muscles. The subendocardial area is particularly susceptible to ischemia. In addition, SAINT depression may be seen on ECG in addition to T-wave changes. Diagnosis: a cardiac troponin rise accompanied by either typical symptoms, pathological Q waves, SAINT elevation or depression, or coronary intervention is diagnostic of ME. WHO criteria formulated in 1979 have classically been used to diagnose ME. A patient is diagnosed with ME if 2 or 3 of the following criteria are satisfied: clinical history of ischemic type chest pain lasting for more than 20 minutes, changes in serial ECG tracings, rise and fall of serum cardiac biomarkers, At autopsy, a pathologist can diagnose an ME based on anatomopathological findings. Classification: myocardial infarctions are generally classified into scintillation ME and non-scintillation ME. A STEMI is the combination of symptoms related to poor oxygenation of the heart with elevation of the ST segments on the electrocardiogram, followed by an increase in proteins in the blood related to heart muscle's death. They make up about 25 to 40% of cases. The phrase heart attack is often used non-specifically to refer to a myocardial infarction and to sudden cardiac death. And ME is different from, but can cause, cardiac arrest, where the heart is not contracting at all or so poorly that all vital organs cease to function. It is also distinct from heart failure, in which the pumping action of the heart is impaired. However, an ME may lead to heart failure. A 2007 consensus document classifies ME into 5 main types. Type 1: spontaneous ME related to ischemia due to a primary coronary event such as plaque erosion and/or rupture, fissuring, or dissection. Type 2: ME secondary to ischemia due to either increased oxygen demand or decreased supply, e.g., coronary artery spasm, coronary embolism, anemia, arrhythmias, hypertension, or hypotension. Type 3: sudden unexpected cardiac death, including cardiac arrest, often with symptoms suggestive of myocardial ischemia, accompanied by new ST elevation, or new left bundle branch block, or evidence of fresh thrombus in a coronary artery by angiography and/or at autopsy, the death occurring before blood samples could be obtained, or at a time before the appearance of cardiac biomarkers in the blood. Type 4: associated with coronary angioplasty or stents. Type 4A: ME associated with percutaneous coronary intervention. Type 4B: ME associated with stent thrombosis as documented by angiography or at autopsy. Type 5: ME associated with CABG. The terms Q-wave and non-Q-wave ME were previously used to indicate STEMI and non-STEMI respectively. Electrocardiogram. For a person to qualify as having a STEMI, in addition to reported angina, the ECG must show new ST elevation in 2 or more adjacent ECG leads. This must be greater than 2 mm for males and greater than 1.5 mm in females if in leads V2 and V3 are greater than 1 mm if it is in other ECG leads. A left bundle branch block that is believed to be new used to be considered the same as ST elevation. However, this is no longer the case. In earlier STEMIs there may just be peak T waves with ST elevation developing later. Cardiac biomarkers. While there are a number of different biomarkers, troponins are considered to be the best and reliance on older tests or myoglobin is discouraged. This is not the case in the setting of peri-procedural ME, where use of troponin and CK-MB assays are considered useful. Copeptin may be useful to rule out ME rapidly when used along with troponin. Imaging. A chest radiograph and routine blood tests may indicate complications of precipitating causes, and are often performed upon arrival to an emergency department. In stable patients whose symptoms have resolved by the time of evaluation, technetium systemib thallium 201 chloride can be used in nuclear medicine to visualize areas of reduced blood flow in conjunction with physiological or pharmacological stress. Thallium may also be used to determine viability of tissue, distinguishing whether non-functional myocardium is actually dead or merely in a state of hibernation or of being stunned. Medical societies and professional guidelines recommend that the physician confirm a person is at high risk for myocardial infarction before conducting imaging tests to make a diagnosis. Patients who have a normal ECG and who are able to exercise, for example, do not merit routine imaging. Imaging tests such as stress radionuclide myocardial perfusion imaging or stress echocardiography can confirm a diagnosis when a patient's history, physical exam, ECG, and cardiac biomarkers suggest the likelihood of a problem. Differential diagnosis. The differential diagnosis for me includes other catastrophic causes of chest pain, such as pulmonary embolism, aortic dissection, esophageal rupture, tension pneumothorax, or pericardial effusion causing cardiac tamponade. Other non-catastrophic differentials include gastroesophageal reflux and Tietze's syndrome. Prevention. Myocardial infarction and other related cardiovascular diseases can be prevented to a large extent by a number of lifestyle changes and medical treatments. Lifestyle recommendations include increasing the intake of whole grain starch, reducing sugar intake, consuming 5 portions of fruit and vegetables daily, consuming 2 or more portions of fish per week, and consuming 4 to 5 portions of unsalted nuts, seeds, or legumes per week. The dietary pattern with the greatest support is the Mediterranean diet. Vitamins and mineral supplements are of no proven benefit, and neither are plant stanols or sterols. There is some controversy surrounding the effect of dietary fat on the development of cardiovascular disease. People are often advised to keep a diet where less than 30% of the energy intake derives from fat. A diet that contains less than 7% of the energy intake in the form of saturated fat, and a diet that contains less than 300 milligrams per day of cholesterol. Replacing saturated with monounsaturated fat is also recommended, as the consumption of polyunsaturated fat instead of saturated fat may decrease coronary heart disease. Olive oil, rapeseed oil and related products to be used instead of saturated fat. Physical activity can reduce the risk of cardiovascular disease, and people at risk are advised to engage in 150 minutes of moderate to 75 minutes of vigorous intensity aerobic exercise a week, keeping a healthy weight, drinking alcohol within the recommended limits, and quitting smoking are measures that also appear to reduce the risk of cardiovascular disease. On a population level, public health measures may be used to reduce unhealthy diets, including food labeling and marketing requirements, as well as requirements for catering and restaurants, and stimulating physical activity. This may be part of regional cardiovascular disease prevention programs, or through the health impact assessment of regional and local plans and policies. Medication. Aspirin has been studied extensively in people considered at increased risk of myocardial infarction. Based on numerous studies in different groups, there does not appear to be a benefit strong enough to outweigh the risk of excessive bleeding. Nevertheless, many clinical practice guidelines continue to recommend aspirin for primary prevention, and some researchers feel that those with very high cardiovascular risk but low risk of bleeding should continue to receive aspirin. Cholesterol-lowering drugs from the statin class may be used in those at an elevated risk of cardiovascular disease. This can be calculated with validated risk prediction tools such as QRISK2. Long-term hormone replacement therapy, when started around the time of menopause, may decrease heart disease following a heart attack. Nitrates, when taken for 2 days, and ACE inhibitors decrease the risk of death.